Thank you very much, Andrea, for this very kind introduction. Ladies and gentlemen, well, after these two splendid lectures, I am a bit disappointed to have to bring you back to the clinical reality, which is sometimes a little bit more disappointing. But I'm glad that Antonio, at the beginning of his talk, was able to introduce at least one of the mechanisms which leads to the development of lymphomas, i.e. somatic or hypersomatic mutation or somatic hypermutation. Now, let's introduce the topic of lymphomas, since I will be the only one talking about that. In the last 30 years, non-Hodgkin lymphomas has doubled in frequency in the Western world, and more so for the extranodal variant, which represent about 40% of the malignant lymphomas, and mainly so in the GI tract, in the skin, and in the CNS, so that today in Western Europe and in the US, malignant lymphomas are the 5th leading cause of cancer death. And while we might discuss, it would be interesting to discuss why this has happened, most probably through the expansion of viral diseases and through a worsening of the environment in general. Now, for 30 years, at the end of last century, we had a kind of holy war among different classification of malignant lymphomas. It was very difficult to have just one classification because the classifications were based just on morphology. And then, well, we had the luck to get some cytogenetic data, some genetic data, and so we were able to then convince the pathologists, for instance, for mantle cell lymphoma, which was very difficult to be diagnosed just on morphologic basis, that if you have a translocation 11-14, if you have a cyclin 1 amplification, this is a mantle cell lymphoma, and it looks like that. So based on that, about 20 years ago, the so-called revised European American lymphoma classification, which became later on the WHO classification, was proposed and accepted by everybody today after a validation study which was decided here in Lugano, the Lymphoma Conference. And this is a classification which is based not only on morphology, but also on everything that we know, genetic, molecular biology, epidemiology, clinical situations, so that at the end we have discrete, very clearly defined subtypes. Now, this is our database in our institute, encompassing about 2,000 cases of non-Hodgkin lymphomas, which is constantly updated so that we know exactly where we are sending also with the outcome. And you see here the most common subtype, the diffuse large B-cell lymphoma, the follicular lymphoma, followed by the other subtypes. We have at least 30 different clearly defined subtypes. Now, after a new classification, the next step forward has been in the last year, what we have published in last September, the so-called Lugano classification, which again was decided here at the conference, and which includes in the staging and in the evaluation and in the guidance of the treatment the use of the PET, the positron emission tomography, which allows us today to a certain extent to individualize the treatment of the patients awaiting the precision medicine. This is the best that we can do for the time being. Now, let's just look at the three most frequent subtypes. This is a diffuse large B-cell lymphoma, representing about 40% of the non-Hodgkin lymphomas. Again, our database and that of Novara, which is based on our through a postdoc which was here and encompassing about 700 patients. And you see here that there has been an improvement in the outcome after the year 2000, which is due to the introduction of the combination of chemotherapy with the anti-CD20 antibody Brentuximab. However, you clearly see that also today, we will probably not cure more than 50% of the patients with diffuse large B-cell lymphomas. If we go to the second most frequent subtype, follicular lymphoma, this is a paper that we have now in press, and encompassing 1,000 patients with follicular lymphoma from our database, from the database of Barcelona and Bartholomeus in London. And you see, again, a clear-cut improvement in the outcome from 1990, 2000, and 2000, and after 2000, so that today a diagnosis, the median life expectancy of patients with follicular lymphoma is around 18 years. However, the disease remains incurable in the sense that they all tend then to relapse. This is just one of the many studies in which it was tried to cure the patients by intensifying the treatment. It's an Italian study in which the patients were treated either with a medium intensity treatment or with a bone marrow transplantation to start with. And although there was a huge difference in the progression-free survival, there was no difference in the overall survival. And this has been shown again and again in follicular lymphoma. Every trial, you can show a difference in the progression-free, but not difference in the overall survival, even not by comparing watch and wait in the patients with very indolent disease at the beginning to the immediate treatment. Now, I will come back then to follicular lymphoma later on to see which possibility will give us possibly the immunotherapy to cure the patients. Now, the third most frequent subtype is marginal zone lymphoma, a very fascinating disease encompassing 3 subtypes. We have demonstrated already a few years ago in the lab that they have different cell of origin, different chromosomal abnormalities and genetic abnormalities. The most frequent one is the so-called mucosa-associated lymphoid tissue lymphoma. Again, a very interesting disease which arises in organs where normally there is no lymphoid tissue, but where the lymphoid tissue is accrued either through an autoimmune disease or through a chronic infection. And this is a subtype which results from a chronic antigenic stimulation. And we have, for instance, shown that if you have a mold lymphoma in the stomach, you can cure that without chemo, but just with antibiotics by eliminating the chronic infection with H. pylori. And recently, we have presented the biggest study in this subgroup encompassing 450 patients who need a treatment. Again, it's a very indolent disease. More patients die because of a second or a tertiary tumors, so you have to be careful not to kill the patients. And in that sense, you must be very careful in avoiding all the very toxic treatment. And we have shown that if a treatment is necessary, the combination, again, of rituximab and chlorambucil is the standard treatment in this subtype of lymphoma. So now let's come to immunotherapy. Well, there is some kind of a natural correlation, I was saying, between lymphomas, of course, and the immune system. But for a long period of time, results were very disappointing, and only adoptive immunotherapy through allogenic transplantation was sometimes efficacious. Now, today, the picture is completely different. What do we mean by immunotherapy in lymphomas today? Well, we mean either the use of monoclonal antibodies, they might be naked like the anti-CD20 rituximab, the radio-immunotherapy, the immunotoxin, or the newer chapter, what we can do to engage T cells. Now, the first breakthrough was thanks to the introduction of rituximab, the anti-CD20 monoclonal antibodies, in the treatment of lymphomas. And the most, the second most responsive subtype besides marginal zone lymphoma is follicular lymphoma. And the Swiss group has shown already a few years ago that by using anti-CD20 rituximab alone in the treatment without chemotherapy and adding a maintenance, you could have about 50% of the patients who will respond for as long as 8 years without needing any other treatment. Now, today, everyone is trying to develop the so-called HER2 treatments, which means a combination of two immunotherapeutics or immunomodulators. The idea being that we know that in follicular lymphomas, the microenvironment is very important. And we cannot really influence positively the microenvironment through chemotherapy. It would even be better if we could spare the microenvironment some of the chemotherapeutic agents. So people are trying to develop treatment which will either act directly as a monoclonal antibodies or through the modulation of the microenvironment. And this is, again, a Swiss Scandinavian study which was presented different times lately, where we have compared in a randomized trial rituximab alone to the combination of rituximab and lenalidomide. And as you can see here, the response rate with the combination of rituximab and lenalidomide has been much superior to what we have seen in the past with rituximab alone. Now, at the last Lugano meeting last June, even triplets of 3 different immunomodulating drugs were presented for the first time, so that this is really the area where a lot of efforts are concentrated today, and there are 3 randomized trials being carried out at the moment, combining chemotherapy regimens in first-line treatment of follicular lymphomas, comparing them to the usual combination of rituximab and chemotherapy. Now, another approach which has been successful is the combination of antibody with radionucleotide, both with the iodine-131 as with the ibrutinib. They both have been successful, and some very positive results were achieved. The problem here is that this is a very complex technology. You have to put the patient for a couple of days alone in a room in order to protect the other patients. It's a complex technology, a very costly technology. And so since at the same time, a lot of other immunotherapeutic possibilities were developed, it has lost a little bit of the appeal which has had at the beginning. Now, the next leap forward was represented by the use of conjugated antibody. And the first one, there are very many now in clinical evaluation. The first one has been the anti-CD30 conjugated antibody, which is conjugated to an antitubulin agent. You see here the anti-CD30, the monoclonal antibody against CD30, which is combined with a microtubule disrupting agent, and which is then internalized after docking of the antibody, and will then disrupt the microtubule networks. CD30 is highly expressed in the classical variant, which represent 95% of the Hodgkin lymphomas, is well expressed in the majority of T-cell lymphomas, and it is a little bit expressed also in some other subtypes of lymphoma. So it was really almost a shocking news for oncologists to see the first data when Brentuximab vedotin was evaluated in patients with Hodgkin lymphomas who were relapsing after autologous bone marrow transplantation, and around 80% of the patients responded to this treatment, even when they were relapsing after autologous, and sometimes even after allogenic bone marrow transplantation. The problem in the Hodgkin lymphoma is that everyone is now trying to move Brentuximab vedotin in the first-line treatment. You know that today we can cure between 85 and 90% of the patients with Hodgkin lymphoma, and that the main problem in lymphoma is how to treat relapsing patients, but also how to avoid a lot of toxicity, since after about 10 years, we have more patients dying because of cardiovascular events or because of second tumors than because of Hodgkin relapse. So, and the first attempt to combine Brentuximab with chemotherapy in the first-line treatment have produced a lot of toxicity, so we are still awaiting the optimal possibility of integrating this conjugated antibody in the first-line treatment. But it has been active. You see here the waterfall plot also in T cells, mainly in the so-called angioimmunoblastic variant, which is the variant which is more aggressive and with the worst outcome. Now, leaving antibodies and discussing how to engage T cells, already in the past, we have had some positive, although not always consistent, results by using interferon. This is a meta-analysis of 10 randomized trials encompassing almost 2,000 patients and showing an overall survival advantage for patients in follicular lymphoma treated with interferon, but only if they were treated with interferon at the same time as chemotherapy and at doses bigger than 5 million per time, and a cumulative dose of more than 36 million per month. That means very high dosages of interferon with a lot of side effects, and these high dosages might give also might perhaps more represent a cytotoxic event than a real immunomodulating event. The next step was the development of vaccine directed against idiotypes. You see here the scheme of an anti-idiotype directed against the CDR regions. Mainly the group of Ron Levy in Stanford has done a lot of work in that field with some spectacular results, but results which could not always be confirmed. This is one study in which vaccinated patients developing anti-idiotype antibodies have a longer response after chemotherapy than the others who do not develop the same level of anti-idiotype antibody, but other studies proved vaccine to be useless, so there has never been a consistent pattern of results. Again, a rather complicated technology, which in the meantime has been more or less abandoned. Now, the next important breakthrough, which was already alluded to by Antonio Lazzavecchia, is that of the checkpoint inhibitors, which should give us the possibility of rejuvenating, so to speak, the T cell and to activate them. You know that the PD-1 is a checkpoint inhibitor receptor which can inhibit the T cell activation through incorporation of the ligands, and by blocking this process, which normally is leading to immunotolerance, by blocking that, we can again allow the expansion and the activation of the T cells, which have been before blocked by the combination of the ligands with the receptor. Now, again, the first very impressive data were produced by two of these checkpoint inhibitor, nivolumab, and another one, pembrolizumab, which are produced by two different companies in Hodgkin lymphomas, who were both resistant to autologous bone marrow transplantation and even relapsing after Brentuximab vedotin, and you see here a response rate of almost 90%, with 17% complete response in this extremely resistant and refractory subset of patients. These are spectacular data which have been recently published in the New England Journal of Medicine. At the last Lugano meeting, in the plenary session, we had a summary of the activity of nivolumab in malignant lymphomas. And as you can see here, while the results for the chronic variant, for the classic variant, sorry, of the Hodgkin lymphoma is spectacular, for the time being, response rate in B non-Hodgkin lymphomas as in T non-Hodgkin lymphomas is somewhat disappointing. It's not as good as we expected. Studies are ongoing. There are discussions of how we can perhaps combine this approach with other approaches, but it has been less than spectacular alone. One of the possibilities would be to combine the PD-1 blockade, for instance, with rituximab. This is the first results of a phase 1 trial coming from MD Anderson, where again you see a very high response rate here in 2/3 of the patients responding in follicular lymphomas, in contrast with nivolumab alone. But again, this is a moving sector, and we expect more data for the future. The other very interesting approach is the so-called chimeric antigen receptor T cells, which means the production of a chimeric antigen which is then transduced to the T cells. You see here that you have an extracellular antibody-derived recognition moiety, which is then transferred sometimes with a co-stimulatory domain into an intracellular T-cell activating domain, and then this is transduced to different models to the T cells, which are then expanded during 3 to 4 weeks ex vivo. And during that time, you can deplete the normal lymphocyte with chemotherapy and then give to the patients these T cells, activated T cells carrying the chimeric antigen receptors, which will produce many chemokines and mainly a high level of anti-CD90 chemokines. Now, this technology, which again is rather complicated, has been used with a lot of success, mainly in the treatment of acute lymphoblastic leukemia, which is very successful in patients, in younger patients, but much less successful in elderly patients, and this is becoming the treatment of choice, mainly in children in relapsing ALL, but are still to be proven to be as active in adults as it is in children. And the last technology which has been developed at the same time as the CAR T cells is that of the BiTE antibodies, so the B-specific antibodies, those antibodies which are connecting not only and attacking not only the B cells, but at the same time also the T cells. Again, they have proven to be very active in the treatment of acute lymphoblastic, of some subtypes of acute lymphoblastic leukemia. They are active also in some subset, mainly of lymphoblastic lymphoma or other subset of lymphomas, but for the time being they are a bit too toxic, so that they have not found an important application in the field of malignant lymphoma. But the last probably topic, which will become, in my opinion, very important in this field, is chronic lymphocytic leukemia, which is a prime example of tumor where we have an important interaction with the microenvironment. And there are now data just recently published showing that T-cell defects in the murine model point to a possible huge therapeutic role of immune checkpoint blockade. CLL is also a disease where we have achieved a lot of progress. We are on the verge, perhaps, of being able to devise a curative treatment for the patients who need a treatment, and I am sure that the checkpoint inhibitors will play an important role in this, and this is the reason why we have now decided to add in our lab also a new group which will devote its research to this topic. So to conclude, while in 2011 the prime time by the Lugano Lymphoma Conference was taken by the Bruton tyrosine kinase inhibitors, ibrutinib, and so on, and in this year it was taken by the PET-adapted treatment in malignant lymphomas. I have no doubt that next time in 2017, the prime time will be taken by immunotherapy. Thank you very much.